As I said, welcome to the first of our developmental disability clinical and research rounds for the academic year. We will be talking today about pharmacotherapy of interfering behaviors in developmental disabilities. And as time goes on, if people have questions, please feel free to interrupt us. If possible, use the raise hand function because it allows for more discussion of things. But if people feel the need to use the chat or the Q&A or whatever else, feel free to do so. So first of all, I have grant funding from several organizations, however, that should have exactly zero impact, although it could be perceived as a direct or indirect conflict, but really should not be seen, it shouldn't be a conflict in any way and won't relate to the topics that I'll be talking about. This is the list of objectives. The third one is a bit different because I think on the flyer you got, it was worded a bit differently, but there they are. Okay, so I think, so first of all, when we're talking about developmental disabilities, it can be defined many ways, but what I'm talking about today would be autism spectrum disorder and or intellectual disability. And I think that with autism and intellectual disability or developmental disabilities, I don't think there are any treatments per se for the underlying problems. In fact, I feel fairly strongly that at least as of today, we don't have any treatments for any psychiatric illness. We have treatments for the symptoms of the illnesses, but not for the underlying problems because we don't know what the underlying biology is. And so therefore we cannot have any treatments of those things, although that's certainly an area of significant interest and research. Since we can't sort of treat the underlying problems, ultimately then the most important treatment should be things like education, speech and language therapy, occupational therapy, behavioral interventions, things like that. But if people's behavior is such that they aren't able to participate in those activities, that's when there may be a role for medication. So if somebody's only able to go to school half the day because of aggressive behavior or really disruptive behavior, then obviously they're missing 50% of their education. Or if somebody is not able to go out and participate in community activities because of their behavior, then they're missing those opportunities to learn, and it's having a negative effect, presumably, on their quality of life. So the way I sort of think about it is if those sort of psychosocial treatments are the most important forms of intervention, then really the goal of medicine is to make people more available for learning and make people more available to participate in those activities and those educational or treatment interventions. So ultimately, I think that the goal of medicine should be to enhance or facilitate other forms of treatment. So behavior modification, education, speech and language therapy, and so on. The unfortunate thing is, though, that there are long waiting lists for all those things, as we know. And in fact, I was looking at a study yesterday published somewhere in the United States. Well, it was in the journal Pediatrics, but it was published a couple of years ago based on the United States. And I think that despite the fact, I think they were talking about ADHD, but despite the fact that, guidelines suggest behavioral treatments should start first, or at least at the same time as medication, something like only about 40% of the people over a 1-year period who had been diagnosed with ADHD and started on medicine were also involved in behavioral interventions. So the fact of the matter is that those things should be the most important form of treatment, but there are long waiting lists, which make them difficult and create for some ethical problems at times, I think. Jude, I've been told occasionally that I speak very quickly, although of course that's everybody else's problem, not mine. So if you can't keep up, just give me the high sign or something. Okay, so we also know that psychiatric problems, in fact, I think all medical problems occur at a higher rate in people with developmental disabilities compared to the general population. And that also goes for psychiatric disorders. However, lots of studies show that people with autism spectrum disorder and intellectual disabilities, they have higher rates of these medical problems and psychiatric problems, but tend to get lower rates of diagnosis and lower rates of treatment. And so we have this real inequity where it's among the most vulnerable and needy members of society often get the worst medical care, unfortunately. So last night, I was just updating this slide. So in terms of understanding the way medicine is used. And so, if you go to PubMed and you type in autism spectrum disorder and treatment, there are, I think, about 22,000 studies have been published since whatever the beginning of PubMed is, whenever they started collating data. If you then add in autism and treatment and drugs. So looking only at medication treatment is, I think, a little over 5,000 studies have been published. And if you then add in the word placebo, it's about 500. And so there is very, very little data and good studies to support the use of medicine in autism spectrum disorder and intellectual disabilities, and yet they are used frequently, which creates concerns as to what the sort of underlying data is, what the underlying evidence is. And this is based upon an HMO in the United States from a few years ago. And because I think it might have been California, but I'm not sure. But because they had 60,000 children with a diagnosis of autism, they could look and see what the rate of medication use was, and looking and breaking it down by gender and by age and things like that. And so, we can see that out of these 60,000, about 56% were taking at least one psychiatric medicine, and 11% were taking at least were taking 3 or more medicines. And this was published, I think, 2015 or 16. So my suspicion is that the number would be higher, especially over the last couple of years. But if we look a bit closer, some of the numbers are a bit concerning. If we look at age group, we can see that obviously the older people get, the more medicines are used. But the fact that 18% of children under the age of 2 with a diagnosis of autism were taking medicine is concerning. And 0.1% of them would be 10 or something like that. But that's still a pretty significant number, given that people under the age of 2 taking more than one medication. And I think some of that could be explained. So there's a category of mood stabilizers, so that could include anticonvulsants. So some of those people may be included in that group. But regardless, 18% of people under the age of 2 taking medicine is concerning. And the fact that a third of people in this HMO under the age of 5 with a diagnosis of autism, in fact, it'd be 32 plus 18, so that's 50% almost we're taking medicine is also very worrying. The other group you see is that in people with comorbid intellectual disabilities, that the more severe the cognitive deficits, the higher the rate of medication use and polypharmacy as well. So despite the fact they've only been, at least in autism, only 500 studies published or so, which include the word placebo, and many of those are probably multiple publications from the same overall project, and some are going to be review articles. There's not a lot of evidence to support it. There's some, but it's not great. And I think we really have to be careful about how we're using medicines. So what I wanted to do today is talk a bit about sort of what some of the target behaviors may be for medication use, and then talk briefly about alternative treatments, and hopefully leave lots of time for questions and discussion. So aggression, and by aggression, I mean aggression towards to other people, aggression towards oneself, or self-injurious behavior, or property destruction. And I suppose calling it emotional dysregulation may be better in some ways, but I think it's by far the most common reason, at least in my practice, that people and parents and caregivers will ask about the use of medicine and whether it might be appropriate. And for most people that I see, I think we can, I often say I can almost write a huge chunk of the report before I even see them. So they typically what parents report is that the emotional episodes, the aggression is precipitated by frustration, for lack of a better word. So things not going the way a person would like. So being told no, having something taken away, having to do something the person doesn't want to do, having to wait for things, losing at a video game or at any kind of game, those sorts of things. And I think beyond that, it's poor impulse control. So if I ask somebody for something and they just look and say, no, you can't have it, yeah, that's a bit annoying. But as we get older, we're supposed to learn how to override our emotions with our thoughts. But if people aren't able to do that, then I think what happens is they just sort of react emotionally, and that's when people have more and more difficulties. So I often think that some of the kids we see when they're upset, sometimes I wonder if they're actually doing the things that we would all kind of like to do sometimes, but we're just socialized not to because of the consequences. And a lot of this obviously has a significant developmental component. So if 2-year-old children are remarkably aggressive, they solve all their problems by hitting people, but they're 2 and they grow to that typically with language development and things like that. But if somebody is 13 or 14 and functions developmentally like a 4-year-old, then their behavior is also going to be like a 4-year-old. And I think that's when problems occur. There was a young man we saw a few years ago, haven't seen him recently, but he was probably about 6'6", and must have weighed 250 pounds. And when he was aggressive, there was a significant potential for somebody to be hurt. And I think that's when it becomes a real problem, and then starts to really limit people's ability to participate in life. So I guess I should preface this by saying, that these opinions are mine, not those of the University of Western Ontario or CPRI or anybody else. But I think the evidence in treating aggressive behavior, impulsive aggressive behavior, is best for antipsychotics. And I don't think that's an idiosyncratic opinion. I think that's what research would support for the most part. So there is actually fairly good evidence for autism and intellectual disabilities, so developmental disabilities as a whole, from randomized, double-blind, placebo-controlled trials than any other type of medicine. And in those randomized, double-blind, placebo-controlled trials, aripiprazole, haloperidol, lorazepam, olanzapine, and risperidone have all been shown to be better than placebo for reducing impulsive aggressive behavior. And in the United States, aripiprazole or Abilify and risperidone or Risperdal have both been approved by the FDA for the treatment of what they call irritability in children and adolescents with autism. So it's they use the term irritability rather than aggression. I'm not sure why, but so drug companies really are not allowed to advertise or discuss what are called off-label uses. So in Canada, all these medicines will be off-label for people under the age of 18. So there's no official indication. But in the United States, they can advertise for it, and that because the FDA felt that the evidence for aripiprazole and risperidone were both, for both of them, was enough that they would be appropriate to market them for that purpose. And so I just wanted to sort of review what I think at the time anyway was probably the best, in fact, probably is still one of the best studies, if not the best. It was published in the New England Journal of Medicine. There were, I think, 8 or 9 universities in the United States participating. And so there were 2 groups of people with autism, obviously with the population, and they had to have a minimum level of aggressive behavior as rated on the aberrant behavior checklist. And there is, on that scale, that's where the irritability scale comes from. Again, it's really aggressive behavior and emotional dysregulation. And you can see that over the course of 8 weeks, people taking risperidone had a gradual decline in their scores on that irritability scale. Whereas people on placebo, there was an initial slight reduction, but then it sort of stayed fairly stable after that. And by the end of 8 weeks, there was a statistically significant difference between the 2 groups. And you can see they diverge very quickly, actually. And so if we look at, the amount of reduction of the aggressive behavior, so reduction in people's scores on the irritability subscale of the aberrant behavior checklist, so after 8 weeks, people taking risperidone were rated as having about a 50% reduction in their aggressive behavior, whereas people taking placebo was about 13 or 14%. Notice the average dose is a little under 2 milligrams a day. And this is consistent with what parents often say or caregivers say when people are started on risperidone or other antipsychotics. They report, at least what I see is they say, there are less aggressive episodes. They are less intense. They're shorter. They're easier to redirect. They take longer to happen so people can intervene sooner. And so it just sort of tones everything down. And again, hopefully makes people more available for learning. It doesn't get rid of the aggression completely, but it doesn't seem to have the same impact on people's ability to function and on their quality of life. So I don't know yet if I've met a parent who's, when we're talking about medicine, who said, oh, well, how much is their aggression going to be reduced? Is it 50% or 30%? What they want to know is it going to make a difference to their child's behavior? And so instead of looking at the percentage reduction of aggressive behavior, if we look instead in this study by it's called RUP, so Research Units on Pediatric Psychopharmacology. If we look after 8 weeks, how many people were rated by their parents or caregivers? So before the blind was broken, if they were asked, their parents or caregivers were asked, is your child's behavior much better or very much better compared to prior to the study? And a little under 75% of parents and caregivers reported that of people taking risperidone reported that their child's behavior was much better or very much better, compared with about 15% on placebo. And in psychiatry, that is a huge difference. You see that perhaps with stimulants and nothing else at all. That's a massive difference. What the authors then did, I think, was a really neat thing. So then said, okay, so we have this group of people, and what we're going to do is then take from the 8-week risperidone group and some other people for a variety of reasons, a bit complicated. But anyway, I said, okay, we're going to just look at the people who responded to risperidone in the first 8 weeks. and people who did well, and then we're going to continue giving it to them for another 4 months. So they would have been on it for a total of 24 weeks or 6 months. Because parents often will say, how long do they need to take it? But also, I think there's a question, was the benefit initially due to sedation or something? And you can see, so this score, so this baseline is actually the end of the double-blind study. So we can see that the score on the irritability subscale had now reduced to 10, where it had been about 23 or something like that before. But you can see that over the next 16 weeks, there was very, very little fluctuation. It's a little bit, but not clinically meaningful in terms of their scores on that rating scale when they were seen every 4 weeks. So there was benefit initially, and it seemed to be sustained at least over 6 months. Every parent, as said earlier, asked, how long does my child need to take the medicine? And my usual response, and I'm not trying to be a smart aleck, is to say, or smart Alice, is to say, they should take it as long as they need to take it. And, that we should periodically think about taking people off and make sure they still need it. So what the authors of this study did, they then said, okay, so people, we know there's benefit after 6 months. What happens if we stop it? And so then gradually the risperidone, for half of the people continuing in the study at that point, half of them had the risperidone gradually replaced by a placebo, and the other half continued to take the risperidone, and they then followed them for 8 weeks. And in this survival plot, so the people in the orange obviously are placebo, and at this point here, as it says, that's at this point in time, people were off the risperidone completely. So they went down by a quarter of the dose every few days. And you can see that for people who now were on placebo, over the course of the next 8 weeks, there was sort of a gradual deterioration in the number of people still, or a gradual reduction in the number of people still taking the risperidone. And so by the end of 8 weeks, only about a little over a third of people who had been on risperidone and had been responders continued to take the medicine. Had not had a significant relapse. So their behavior had gotten much worse, people in orange, whereas people in purple and the risperidone, their behavior remained pretty similar. So most of them continued to take the medicine. And hadn't had a significant increase in behavioral problems. So I think what the study is really elegant in a lot of ways, because they showed that risperidone is helpful in the short run, that it is sort of prolonged over 6 months. And then, but when it was stopped at that point, most people relapsed and the behavior got worse. It's a very small study. There's only 16 in each group. And that's because the ethics boards at the universities involved said they really couldn't continue, because it was clear that stopping the medicine was harmful to people and it wasn't ethically appropriate to continue. So the only other long-term study that I know of looking at aggression was in aripiprazole, and long-term being a year. And this is a huge problem across the field, is that most studies are fairly short-term. And in this study, it was sort of similar to the risperidone one I just showed, in that the week 0 here is at the end of a previous double-blind study of aripiprazole or Abilify. And so there's several groups, and it's a bit confusing, but the group with the triangle here, so these are people who had been in the double-blind study previously, but had been on aripiprazole or Abilify and had shown benefit. And what we can see is over the course of a year, or 52 weeks, that in general, those people maintained their improvement. So it didn't wear off over time. Generally, that they didn't show a lot more improvement after 8 or 12 weeks, but the improvements that they had seen continued. And so 2 other groups, so the group with the squares are people, the open squares, these are people who in the previous double-blind study of Abilify had been taking a placebo, so they were now given the actual medicine. And then there was a further 48 people at the bottom who hadn't been involved in the double-blind study. I'm not sure why they were included here. But you can see for both those groups, there was sort of an initial improvement in aggressive behavior, and then it was sustained over the course of a year. So and these are obviously all group averages. They don't tell us anything about individuals. We can see that for people taking Abilify over the course of a year, that benefits tended to be sustained and prolonged. And this is where, hopefully it allows people then to participate in school more appropriately and to be there full time, that their families can now start going out and doing things in the community more, so they get that kind of exposure. And I think it just makes a significant difference to people's quality of life, both the patient and to their family members. If that's unclear, please say so and I can try and go over it again. So, we know that there are significant side effects with antipsychotics. Sedation can be when they're used appropriately, although really it rarely is. I think when these medicines are used carefully, every parent says, I don't want my kid being a zombie. And I say, I don't either. That I know that if somebody's asleep all day, there are not going to be any behavior problems at all. I'm 100% certain of that. But there's not going to be any behavior either. And so it doesn't really benefit the child that we're talking about. And so if parents say, that he's really sedated or he's sleeping all the time, I would say that's a problem. But realistically, I don't think that's typically a problem. But for whatever reason, even though there's no daytime sedation, people do seem to sleep better at night. I think a bigger problem with the antipsychotics, perhaps more with the newer ones, what we call the atypical antipsychotics, is weight gain. And Naira and Sukumar, the resident working with me right now, he and I were talking today about, is it actually the appetite goes up or is it satiation goes down? And I think it's probably the satiation goes down, but and it's a byproduct of that. So people never feel full. And so they just eat more and more because they're hungry all the time. And this is a huge problem. So if we look at the risperidone study again, I was mentioning a moment ago. So after 8 weeks, people taking risperidone had gained on average about 3 kilograms, whereas people on placebo had gained a little under 1 kilogram. And after 6 months, people who are still taking risperidone had gained about 5 kilograms. And which is problematic, and obviously is more than people would have gained anyway, just by growth. I think, though, these numbers may be a bit misleading because I think it is not normally distributed. I think it is really skewed. So most people gain a bit of weight and a few people gain a huge amount of weight. And so I think it's probably the median may be a better number than the mean. But regardless, it's a significant problem and we don't have any great ways of addressing it. If there is a silver lining, and I'm not sure there is that after about 6 months, people's weight tends to start to plateau. So people gain a great deal of weight initially and then it sort of plateaus. Their appetite doesn't change, but they don't seem to gain weight at the same rate after that. Okay, we're looking at group averages though, and the problem with averages, they don't tell us anything about individuals. And I don't think we're great at predicting who's going to gain weight. To my knowledge, and I haven't really looked this carefully recently, but I think at one point in time, the best predictor we had of who was going to gain weight was people who were overweight to begin with. And that doesn't seem like rocket science to me. So other symptoms, side effects that we worry about or look for anyway, are extrapyramidal symptoms, so stiffness and tremors, and then tardive dyskinesia or abnormal movements. I think, though, that these are, well, it says less with atypical antipsychotics than they may be. We also use far lower doses of these medicines than we used to. When I started my residency in '93, risperidone had just been approved for use in Canada. And I think, it wasn't unusual to see people taking 10 milligrams a day. And I think that's a pretty unusual dose now. I think I haven't seen a child or adolescent with tardive dyskinesia, I'm going to say in probably 10 years. Although a mom did email me recently saying that her son had developed some unusual movements, so maybe I'm going to have to take that back. We also know that there are metabolic abnormalities associated with antipsychotic use, I think often secondary to weight gain, but not always. And this can include sort of increased insulin resistance and higher rates of type 2 diabetes. And then something called neuroleptic malignant syndrome, which is rare. I've never seen it. I don't expect that I will, but is potentially life-threatening and consists of stiffness, like what they call lead pipe rigidity. So people can't really even bend their arms, high fevers, and confusion. And I try to warn parents, it's all three of those together. I ask them, please don't call me if your child has a fever. That's completely explainable. It's all three of those things together. So, I think the evidence for antipsychotics in aggressive behavior is better than for any other medicine, frankly. There are lots and lots of other medicines that have been tried. And I remember once when I was a resident doing a presentation on autism and medication use, and I think almost the entire, at the time, CPS manual or close to it had been used in people with autism at one point or another, and in people with intellectual disabilities. So SSRIs, people seem to really want to use SSRIs a great deal in treating aggressive behavior. And I think there's essentially no evidence to support that use whatsoever. And that unless the aggression is directly associated with anxiety or depression. So certainly we know that children with obsessive compulsive disorder at times can become quite aggressive if they're prevented from completing their compulsions, or if when people are really anxious or afraid of going somewhere, if they then might become aggression. But outside of that, SSRIs, I don't think there's any evidence they are useful whatsoever. Stimulants and Strattera, so they both help with impulse control somewhat. I don't think they're as effective as stimulants. So alpha agonists and beta blockers. So they're both medicines used to treat people with high blood pressure, or that was the intended use initially. So with alpha agonists, the example would be clonidine or Intuniv. And I don't personally think they're anywhere near as effective as antipsychotics are, but they, in the last couple of years, I've actually seen a few people who I wouldn't have expected to respond to clonidine actually show significant improvement. So personally, I've changed my mind somewhat, but I think in general, if people are going to be exposed to side effects of medicine, then we might as well use the most effective medicines available. And personally, I would say those are antipsychotics. In Europe, I think they use a lot more anticonvulsants than we do here. And there is evidence that they're helpful, just not as helpful, I don't think, as the as antipsychotics. And there is older literature about the use of lithium. I cannot recall the last time I prescribed lithium personally for impulsive aggressive behavior. Lithium has all kinds of side effects. And I think there are other more effective medicines. How are you doing there, Judith? All right. So I don't know if people want to take a sort of stop and talk about this here, or if we should just plow on through. But if anybody has anything that they would like to say now that seems pressing, feel free to do so. Otherwise, we will move on. Dr. Mitchell has raised her hand. Why don't you go ahead, Claire? You just have to unmute yourself.
Yeah, hi, thanks. So I'm sorry, I was with a patient, so I missed the beginning. So you may have covered this, but I'm wondering what your thoughts are about aggression as a sort of standalone symptom. I guess my own approach is to think of aggression as being caused by something. So, for example, some people with ADHD, aggression is just part of their impulsive response to, something.
Yep.
And in those kids, a stimulant can be quite helpful. If some people have anxiety and aggression is part of their sort of fight or flight response, then the SSRIs can be helpful. So I guess my question is, do you think aggression can occur just in isolation without other drivers and comorbidities?
Well, I will pretend I'm a good psychiatrist. What do you think?
Well, I think that it's probably possible, but I guess I often find that there is a driver of the aggression, whether that's impulsivity, anxiety, sort of that reactive anxiety and PTSD type or developmental trauma. So I find it often to be a symptom of something else that is often more treatable than aggression per se, although I'm sure there are exceptions to that.
So, I mean, I think certainly it's in talking about these, I think the assumption is that we have ruled out other possible explanations. So there, over the years, I've seen a couple of people, one female who was a sort of was in the residential program here twice and for extended period, who was remarkably self-injurious. But I think whenever she had a sinus infection, her the rate of self-injurious behavior really skyrocketed. And there's another boy I used to see a long time ago similarly. And so I think what I say to parents and residents is, if there's an acute worsening and really significant dramatic worsening of aggression or self-injurious behavior, I think it's really worthwhile to make sure that we have covered all of our bases in terms of possible explanations. It's not always easy to examine people, right? So you'd often wonder about dental problems, but getting people in to see a dentist quickly isn't always easy, and especially people who may not be cooperative with exams. And certainly, I think anxiety for some people can be an issue and may be related to aggression. I think, assuming we've ruled those out, I think the bigger problem really is a developmental component, which I might have said before you arrived, Claire. Just that, I think we know that 2 and 3-year-old kids are very aggressive, but they're 2 and 3, nobody gets hurt, and they tend to grow out of that as their language improves. But I think for people who are older but function like a 2 or 3 or 4-year-old, I think that's when it becomes a real problem. And I do think that impulse control is a huge component of it. And so and that's where I think in people who are verbal, well, people often say, look, when I'm angry, I know that I should do X, Y, and Z, but when I'm angry, I never stop and think about doing X, Y, and Z. I just react. And so if medicines help with aggressive and self-injurious behavior, I think what they do is reduce that impulsivity at some level.
Yeah, I mean, I think as you've illustrated, it's a very complicated symptom, I guess, and that's why you're talking about it. So yeah, thank you.
But I think particularly for nonverbal people, though, it's really difficult to get at other things. And so parents often with kids who are self-injurious, parents will say, is there some kind of pain involved? And there's no real way to assess those things, unfortunately.
Right, and obviously the lower the developmental level, the more difficult that becomes, for sure. And it may be, that aggression is just their way of responding, and it has nothing to do with pain or anxiety or anything else. It's just their pattern of behavior. Yeah.
Right, and I think that's where the behavioral part needs to be involved also, though, because there was a young man I saw years ago, and I recall that they lived in an apartment, and whenever he got upset, he would yell and scream, and the neighbors had started to complain, and the landlord had said something. And so eventually what happened was every time he started to yell and scream, his mother would give him some kind of candy or treat. And he learned very quickly, and I'm not saying at a cognitive level, but he learned pretty quickly that if he wanted something like that, all he had to do was yell and scream. And I think that's where medicine might help with impulse control, but it has to be accompanied by other interventions.
Yeah, 100%.
Ben, did you want to say something? I've kind of lost you here, Ben. Actually, give me a second. And Ben, if you would like to unmute yourself, feel free to go ahead.
Okay, am I on now?
Yep.
Actually, just to follow through on Dr. Mitchell's comment, I'd like to reserve my comments on the understanding of aggression and mention that CPRI about 40 years ago did a major symposium on aggression in the mentally handicapped, and it covered psychosocial, anatomical aspects. And I'd like to maybe comment on the results of that at the end of your talk.
Okay, sure, that'd be fantastic, Ben. Because especially the psychosocial part, because in looking at the use of pharmacological agents among children in the United States, there are clear sort of racial differences, unfortunately, and SES differences and things like that shouldn't exist, but they do. Unfortunately. Okay, so we will come back to Ben. Sorry, Ben, were you going to say something else? Okay. So the other, so the next area really is inattention and hyperactivity. And so ADHD is a relatively common condition among children and adolescents in school. And again, I think it's commonly comorbid in people with developmental disabilities. There's been a lot written in sort of medical literature and psychiatric literature the last few years about sort of the overlap between ADHD and autism in particular. However, I don't know what to make of that, because I think on paper, a lot of people with autism have ADHD, but I think it's quite different from what we see in children with run-of-the-mill ADHD. I think it's quite a difference, but it on paper, they look very similar. But as with aggression, I think that the person's developmental level is a huge component of this. So we think about sort of the stereotypical case of ADHD is ADHD exists when you have a discrepancy between a person's developmental level and their attention and concentration and impulse control and things like that. So we have a 10-year-old child who functions like a 10-year-old, but their attention span is like a 5-year-old. So there's a clear discrepancy. But if you have somebody who's 10 years old and functions like a 5-year-old, if their attention span is like a 5-year-old, it's not necessarily inconsistent. It doesn't mean it's not a problem, but I don't think that's the same thing as ADHD. And in fact, there is sort of this clinical dogma that the lower you go in IQ, the less effective stimulants become. It's something that really hasn't been studied well, because it'd be very difficult to design a study from scratch sort of aim to answer that question, but that is sort of what the belief has been, I think, for quite a long time. In Canada, we have several different medicines to address ADHD symptoms. So in general, stimulants should be the treatment of choice for people with ADHD, and I think the same in developmental disabilities, although depending upon other factors. So in Canada, we have methylphenidate, which is Ritalin, Concerta, Bifenthrin, and Foquest, dextroamphetamine, which is Dexedrine and Vyvanse, and then Adderall, which is a combination of amphetamines. And one thing that people sometimes ask, these are amphetamines, aren't they addicting? And I think the short answer to that is when they're used appropriately, no, that certainly they can be abused, but when they're used appropriately, there is really not a lot of tolerance, if any, to the sort of the cognitive effects, and the abuse is unlikely. When used appropriately is the key element of that, though. And studies have been looking at this for a long time, and initially studies were a bit equivocal, but I think that was perhaps because of subject selection more than anything else. I think more recently studies have shown that stimulants definitely can be effective in reducing inattention and hyperactivity in people with developmental disabilities, but they're less effective than they are in children who, quote, just have ADHD, and they're less consistently day-to-day effective. So they're effective, but not as good as they are in people who don't have a developmental disability. People with developmental disabilities also tend to have higher rates of adverse effects. I think particularly the mood side effects, but also perhaps with other things as well. Sarah, were you going to say something? Nope. Okay. So one study from several researchers in Europe, including England, Emily Siminoff was the first author. It was published, and I think this was people with moderate intellectual disabilities. And they found after 8 weeks, I believe, that people taking methylphenidate had a greater reduction in overall ADHD symptoms, so both hyperactivity and inattention, relative to placebo, rated by teachers and parents. So certainly some benefit, but not what you might expect to see in people with straightforward ADHD. And we know the side effects of stimulants are commonly known. The most common ones being insomnia, so difficulty falling asleep, and then anorexia or reduced appetite, particularly at lunchtime. So atomoxetine or Strattera was originally created with the idea that it would be an antidepressant, and theoretically it should be, given the way it works. It's a reuptake inhibitor of norepinephrine, which is how the tricyclic antidepressants work. But studies done, and it was created, I think, in the 60s. And so studies at the time suggested it really was no better than placebo, and so it sat on the shelf for a long time. In the 90s, Eli Lilly, the company that owned the molecule, went back and started doing studies in ADHD, and that's what they were granted approval for. In straightforward ADHD, it certainly is better than placebo. I think most people would say it's not as effective as stimulants. What I'll sometimes say to parents, though, I don't know if we need the most effective medicine for a child. We just want a medicine that's effective enough. And there have been very, very few studies looking at it in people with developmental disabilities, unfortunately. One of the best, in fact, perhaps the best, though, and it's a bit complicated, but was done by several universities. Ben Handon is in Pittsburgh. I think people in Ohio and perhaps the NIH were involved also. So there were multiple arms. So this group at the top here with the diamond, these are people who are on placebo. So they got no behavioral training for the parents and no medicine at all. They were on placebo. The group with the squares, the boxes, they received a placebo, but also had parent training. And so obviously parent training showed an improvement relative to nothing at all, which is good to see, but what we would expect. The other two groups, so there's, and they sort of overlap at the end here. There is the group in with the circles, and that's people who only took atomoxetine. So there was no, or Strattera, there was no parent training involved. And then it's covering up a triangle, which was atomoxetine or Strattera plus parent training for hyperactivity. And although they look similar, the effect size, so the difference from placebo, actually using standard deviations, was greater for the combined treatment of atomoxetine and parent training. It was greater than atomoxetine or Strattera by itself. And also, it's going to have a longer lasting effect because children hopefully are learning those skills, as are their parents. So it was nice in that it included the behavioral training arm, which is what, as I say, that's really the most important part of these treatments. I think that my opinion about Strattera goes back and forth. Some days I think it's great, and other days I think it's a very expensive placebo. But certainly it has less adverse effects than stimulants, which for some people may be a significant issue. It definitely doesn't worsen tics, and it can be given once daily. One problem with Strattera, though, is for people who can't swallow capsules, it's in a capsule. You can open it and put the medicine on something, like or in water, or you can put it on pudding or applesauce, whatever. It is unbelievably terrible tasting. And I haven't seen that many kids who are willing to take it more than a week or so because of that. So it does have insomnia and appetite suppressant as a side effect, but less than with stimulants. And certainly people can get stomach aches, especially if they take it on an empty stomach. So it should be taken with breakfast. It's a warning from Health Canada that its use is associated with thoughts of suicide. And there have been problems with people having elevated liver enzymes, suggesting liver problems. And I believe 1 death due to liver failure, but that's out of 8 or 9 million people who've taken it. And so I think when something happens in 10 or 15 people out of 8 or 9 million, I think we have to start looking to see, is there something different about those people? Not to blame the victim literally, but more that just, maybe there's something different about their metabolism or their makeup. Claire, did you want to say something?
Yeah, so when Strattera first came out, there was reports of the like the corrosive nature of the powder, that it could cause damaged mucous membrane. So that was a reason that it could be used where there were addiction concerns or diversion, because if you snorted it, it burned the nose. And I think there were a couple of case reports of corneal abrasions. So I just wondered if that has panned out. So I typically have told patients that they cannot open the atomoxetine, but I'd be interested to hear other people's experience.
So I've seen a few people who've done it, and the Canadian Apothecary and other sort of pharmacies where they compound medicine will do it. It doesn't really change the taste. But certainly I heard from a few parents, that if they'd broken it and given it to their kids, that they then would, and didn't wash their hands right away, that they could get, it really would burn their eyes and things. And I think, and actually it was a medical student, Anwar Hamoud, who's now a resident in psychiatry, but I think his undergraduate degree was in pharmacology. And we're talking about this a few years ago. And I think because the molecule is actually atomoxetine hydrochloride. And so you're saying that that's probably what the problem is that contributes to the taste and the corrosive effect you're talking about.
Okay.
But yeah, I mean, I've given up telling parents that they can break it open, because honestly, it's when I say it tastes bad, I am not really indicating just how bad it tastes.
Oh, you gave it a try, did you?
Well, it might have looked a bit funny with some white powder on a finger, rubbing it against my gums, but thankfully the police didn't break it at that time. But yes, a parent had given me some that there was left over. I don't know why, but it was just horrifically bad.
Okay.
So the other thing is, antipsychotics, and they are used for everything, but antipsychotics have been repeatedly shown to reduce hyperactivity. And in fact, in the risperidone study I mentioned earlier, they also measured hyperactivity sort of separately, although it wasn't the primary outcome. And they found there was a reduction in hyperactivity. And, if we look at the same group, the RUP group, they also did a methylphenidate study in people with autism. But if we look at their risperidone study and their placebo and their methylphenidate study, different samples, different goals, things like that. So we shouldn't necessarily compare them directly, but if we do, they look pretty similar actually. And certainly we know that antipsychotics can help with ADHD in and of themselves. They don't tend to be used much purely for that purpose, because there are other more effective medicines, but they can help. And given what I was saying earlier about the idea that the lower you go in IQ, the less effective stimulants are, or maybe, I think it's an important question to ask. And so the only study that I know of that has actually looked at this directly was done in adolescents with moderate intellectual disabilities again. And there was no placebo arm, but it was double blind, and people either received methylphenidate or risperidone. Now, fairly small study. And it was only 4 weeks, so may not have been enough time for risperidone really. But regardless, as you can see here, their reduction in ADHD symptoms, in oppositional kind of behavior and things like that was almost identical in the two groups. So there was no differences whatsoever. Which sort of supports the idea that antipsychotics can be helpful, particularly the lower you go in people with intellectual disabilities in IQ. I don't know if they really are the same. So my own sense is that stimulants, when they work, I think they are much more effective than risperidone is. But I think in this population, they might not help as wide as a range of people, and might not help as many people. Whereas risperidone may be less effective, but perhaps helps more people overall. And so if we're just looking at group averages, it comes out as being equal, but I wonder if the curves themselves are a bit different. But that's speculation on my part. So I just want to talk very briefly about alternative treatments, and then we can sort of open the floor and we'll come back to Ben. But when I was in medical school, Susan McNair, who's a family doctor, I think she's still practicing, and she was giving a lecture once, and she talked about how she goes out of her way every month to read, People Magazine or Us Weekly or In Touch or Cosmo or Glamour, because there's always some new medical treatment that they're touting. And I think that's a really good idea. And I think it's important to be aware of what people are asking about, what patients are asking about, what their parents are asking about. And, there's all kinds of alternative things. So antifungal agents have been proposed as a treatment for autism. There may be, from my reading of it, weak evidence that there may be higher rates of Canada in people with autism, although I'm not convinced of that. And that may also have nothing to do with, it may have something to do with, what people are getting into and other immune things. The, people have used homeopathic and naturopathic remedies and chelation as well, and dietary interventions. So gluten-free and casein-free diets in particular. And so that would be removing wheat products and milk. And it's a really difficult thing to do any kind of study of dietary interventions, because first of all, doing a blinded study would be very, very difficult, and people don't follow diets anyway. But the two studies that I know of that actually were quite well done, I think, they had a group of children and adolescents with autism, I believe, who were also on gluten-free diets. Now, I don't know why the parents of these people agreed to participate. It seems a bit unusual. But anyway, so they stayed on their regular diet, but over a 2-week period, children so they were divided into two groups. People in one group received a cookie at lunch and dinner, I think, for 2 weeks, which did not contain gluten. And people in the other group received a cookie at at lunch and dinner, which did contain gluten, but they were identical appearing and I guess identical tasting cookies. And there was no difference in behavioral changes in those two groups over a 2-week period. So it's maybe the best we can do in looking at these things, but I would say that there's no great evidence for any alternative agents. And again, it's really important to know because people ask questions that to this day continue to surprise me at times. So, Alex Jones, who recently had his lawyer give away all the contents of his phone, apparently to some plaintiffs. Anyway, so he sells something called Child Ease, and which is supposed to calm the overactive child. And the only way I know about this is a parent actually asked me, their son who was 16 or 17 had bought it, and a parent was asking me what I thought about it. I wouldn't have known otherwise. And so obviously, marketing works. We know that Mr. Burns and the Simpsons found brain and nerve tonics to be very effective. And for some reason, some of the most concerning for me is, and again, two parents have asked me about this, not recently, but a while back, and it's by a woman who lives in Mexico. Anyway, she believes or claims that autism is secondary to parasites, and therefore what we really need to do is eliminate parasites. There's no evidence to support this from a scientific perspective, but she's written this book, and it's more commonly used this approach than you'd think. And so basically, she's developed this whole idea that it's due to parasites, and then we have to get rid of those. And there's this real sort of, I think it's an 18-day protocol, and involves giving children and adolescents chlorine dioxide, which essentially is diluted bleach. And you have to get, you have to drink it, and it says, 8 doses throughout a day. And then you have to have a bath with it at the end of the day, as well as at least one enema every few days of again, diluted bleach. In addition to ocean water, I don't know how, well, I guess ocean water is salty relative to tap water, but I know the other benefits of it. And diatomaceous earth and mebendazole, which is an antihelminthic for parasitic infections. And it's, again, one of the parents who asked me about this is he has PhD in chemical engineering, and I wanted to look at him and say, are you out of your mind? Like, why would you think that this is a legitimate thing to do? And yet, again, it was he who brought it to me. I think, thankfully, in all of this person's writing about this, she always talks about the phase of the moon as being a way to sort of involve the timing of the treatment. And I generally tell parents who've asked about this, any medical treatment that depends on the phase of the moon, it's probably not a legitimate and scientifically well-studied medicine. Now, I may be kidding myself, but I don't know of any medicines that really depend upon the phase of the moon to be effective. Yes, I mean, this comes up all the time with this particular approach. So ultimately, medicine shouldn't be viewed as a treatment, but as a way to make other interventions more effective, and they have to be used carefully and judiciously, with an eye, always asking ourselves, do people need it? Is it helpful? Is it causing problems? Ben, do you want to go ahead and sort of talk about what the outcome of that symposium was?
Yes, the symposium, it's now about 40 years ago, but there's which covered the psychological, the psychiatric, but the thing that stands out in my mind was a lecture by Dr. Montemuro, the professor of anatomy. And he was saying, if one considers the brain consisting of the cortex as the rider and the thalamus as the horse, he says it may take about 1 million years before the rider will be able to control the horse. In other words, the connections between controlling the emotions of man. But I think you made a very important caution at the very beginning when you indicated that before managing or introducing medication for aggression, one does work with a team, the psychologist, the social worker, to take a look at the psychological triggers of aggression, any social factors within the family that can also be producing it. So those things are extremely important before one sort of jumps to the aggression. The other thing is trying to understand why these medications work. And when one does introduce a medication, I was also extremely fearful in my practice about the side effects, and think about every 3 months I would ensure that they were the child was checked out for diabetes or liver function, and that blood work would be taken, because I think there was one hypoglycemic attack which was very severe, and a hyperglycemic attack which was very severe. So without monitoring the biochemical and the neurological effects of medications, those are important. But I think you've given us a very good update on the current indications. And yes, we did have a lot of quackery in my day as well.
And it still exists, right? I think that parents of kids with disabilities, I think, are probably very easily taken advantage of. Parents will do whatever they can to help their child. And I think, I would never personally use the word cure, but for many people, if somebody else does use the word cure, I think that's far more compelling than what I would offer. There's a comment from somebody with the unique name of Blackberry, but anyway, I guess it's research in motion, isn't it? Anyway, I might also add the team of behavior analysts to explore the environmental factors and contingencies that may be contributing factors. Absolutely, and I think that's what I meant by behavioral intervention. People would be sort of behavior analysts or behavior consultants. I think, unfortunately, though, as time goes on and waiting lists get longer and longer and longer, and things become more, my worry is that I can say to parents, like, ultimately medicine is just a way to make other interventions more effective. My personal concern is that medicines are going to become the intervention. And I hope that I am incorrect about that as time goes on, but that's just, when I look at where things are going, it's certainly a concern that I have. Dr. McLean, welcome and nice to see you. I guess you can take the doctor out of CPRI, but you can't take CPRI out of the doctor. But anyway, Jennifer, if you would like to unmute yourself. And you're unmuted now, Jennifer. You should be able to go ahead. So I can't hear, maybe it's me, but Jude, can you hear anything? No, so I'm not sure what's going on, Jennifer, but I can't hear what you're saying. If you want to write it in the chat or in Q&A, we can come back to that. But let me move on a bit and we'll come back to Dr. McLean. Maria Sotosanti, Maria, do you want to go ahead? All you have to do is unmute yourself.
Hi, can you hear me?
Indeed, how are you?
Good, how are you?
I'm well, thank you.
Thanks for the talk, it's wonderful. Just wondering, I've had a lot of parents approach me about CBD use in children, particularly with autism. Just wondering what your take is or how you would approach that.
So, again, these are my opinion, but as far as I can tell, the human biome is the cause of every medical problem that people have now, and CBD oil is the treatment for every medical problem. My understanding, and Jennifer and I have actually talked about this quite a bit in the last years, is that the only true indication and good evidence is in the two epilepsy syndromes in early childhood, right? So I think there's good evidence in Dravet syndrome, and I can never remember whether it's Landau-Kleffner or Lennox-Gastaut, but I think those are the only things with really good evidence. I don't know. I don't think there's any good studies of it in autism, sort of placebo control stuff, in part because of regulatory issues in the United States. But what I can say is that I'm going to say about 40 parents have tried CBD oil with their children rather. And I think after a month or two, only 1 or 2 have continued to take it. So I think if it was really effective, people would continue to take it. My experience has been that people have generally stopped it within a few months, which to me means it really hasn't made a significant difference. I mean, what's been your experience?
I've had one child where I'm not convinced there's a significant difference, but they've just continued with it. And then other parents have approached for prescription, but never actually went through with it.
So what I tell parents, or suggest anyway, and this would go for pharmaceutical things as well as dietary interventions and CBD oil, that it's really worthwhile to get some input from people who don't know that you're making a change. So, and I apologize to any teachers in the audience, but I may often suggest to parents that they may neglect or forget to tell the school that they've changed their treatment. And that way we can get an unbiased opinion, which I think can be incredibly valuable. And so that's, in order to get that, really, is there really a change or not?
Yep. Thank you.
Yep. Jennifer, have you solved the technical problem that you had?
Can you hear me now?
Oh, yes, indeed.
There we go. So yes, what I was going to capitalize was on all the great discussion that you've already had in your presentation, which is excellent. We've worked together a long time over the years. I just wanted to make the point, though, is you can really see what's happening with the lack of readily available behavioral help for families. So this is what I'm seeing more and more over the last few years, is that the community physicians, I mean, and I'm not talking about pediatricians necessarily, but family doctors as well. I mean, the child presents, the child is getting kicked out of school and the parent doesn't know what to do, and they go, and of course the physician's sort of saying, okay, well, my experience is I can't get behavior help. I don't know what to do. Let's start meds first. Which makes sense. But what I'm finding is that they're not necessarily discussing with the parent about whether there's, where the child's developmental level is, or figuring that out, or talking about parenting, not with expectation of someone who's chronological age, but where their developmental age is. And then the other part is they're not necessarily even getting them on the wait list for behavior help when there are a lot of problems. Now, there'd be different things along the way that were available virtually, but again, some of those are no longer available, but they got to get at least on the wait list. And the medication. And then the other part is that, as we know, you start slow and you go up slow to find the best fit, but you do your consult and saying, just try this. You need to be able to follow up as well. Is it effective? How effective is it? Is it worth continuing or trying something else? And so I think the issue about not having the behavior help available has really turned a lot of things on edge, in the sense that it's hard to do if you don't have the team to do the multimodal approach, because it's not necessarily there. And so you can see this happening more and more.
Yeah, absolutely, Jennifer. And with so the multimodal treatment of ADHD study was published initially in I think about 2001, and it and there is a point to this. I will get to it slowly. It was I think about not quite I think like a 1.5 year long study of treatments for ADHD, but then they continued to follow those people long term. And initially, stimulants were, even adding behavioral interventions to stimulants didn't make a huge amount of difference. But over the long term, the behavioral interventions made a huge difference. And that's really what we want. We're not, it's nice that these medicines help over 12 or 16 weeks, but frankly, who cares? What we really want to know is are there benefits, and are they sustained over a long period of time? And that's where you really need the behavioral and speech and language and education and things like that. And ultimately, I can talk about these things sort of in a vacuum, and they are fairly straightforward. But Dr. Ogilvy and I have a young man that we've been seeing at Victoria Hospital, who has a whole host of ongoing problems, in addition to really significant aggressive behavior. And it makes it sometimes really difficult to know what to do. And that's where even I think sometimes a pharmacologist or pharmacist can be really valuable, just in terms of interaction with other medicines. And what's going to be safe and how they're going to affect each other. And I think that makes a huge difference.
And Rob, can I make one little last comment about the children
course.
that we, can I make one last comment
Yeah,
about
no,
the children?
of course.
For the children we see with really severe developmental delays, they are getting bigger. And of course, their aggression is now more of a bigger problem because they are bigger. And I also get from the community physicians, well, what do you expect? I mean, they're only this level developmentally compared to their chronological age. Some medication is not going to help for that. We should be treating them where their developmental level is. So they're not even being offered a trial to target a particular symptom.
Yeah, and that's what, so I had a patient yesterday, and I've known him for a number of years, and in the last year or two developed epilepsy and has been really difficult to treat, but his aggression has gone through the roof, and his parents are saying, his parents haven't been able to go out for dinner. Obviously the pandemic has had an impact on that too, but they just look exhausted and they haven't been able to do things. He's not able to go to school. The mom's family came to visit and to help out, and they basically said they're not coming back. And so it's had a huge toll on everybody, including the young man, but also on his family, and that's going to have an impact on him in the long run as well. Where I sometimes struggle, Jennifer, is in really young kids, and I have this ongoing debate with myself, usually inside my head, but I don't have a younger age at which I would say no, I would never use medicine. I can say that under the age of 4, I think I prescribed medicine exactly twice. But it comes perhaps more with the ADHD stuff that, if we really believe in early intervention, then wouldn't it make sense to prescribe stimulants to 4-year-old kids who clearly have ADHD rather than waiting? And I think if we really believe in ADHD in early intervention, it makes complete sense. The only thing I can say is it doesn't feel right, but at the same time, I don't have a good reason not to either.
And therein lies the controversy.
Therein lies the rub.
Mm-hmm.
Indeed. And I wonder if any of the pediatricians, Maria or Afzal, I guess I'm wondering what your thoughts are as sort of community pediatricians about using medicines in younger children.
I've used, in terms of ADHD, I think my minimum has been about 5, and that's usually been in children who they clearly can't function and they need something. Younger than that, maybe 4, I've tried clonidine, but in terms of things like risperidone, probably age 5, 6. Usually I try to get the help from a psychiatrist or developmental pediatrician just to kind of make sure I have that support. But sometimes, like you said, the wait lists are long and it's a bit difficult if they can't function. So I try to give something to help if it's really to the point where they're not functioning and it's destroying all relationships.
Yeah, and I think oftentimes, problems they may be apparent in younger kids, but they become more problematic, I think, when people start formal schooling in grade 1, especially with kindergarten being more play-based now. But and I guess the kids that I've used medicine on who are under the age of 5, I think they have had multiple problems. So it's not just they were hyperactive, also had cognitive problems and significant aggression and a host of other issues as well.
Right. It's mostly the aggression piece
Yep.
that makes me consider trying medication because it's becoming a safety issue.
Right. So one of the only 2 people under the age of 4 that I've ever prescribed medicine to was a child who was about 3.5 when we saw him. And even at that point, his parents were, I think, frightened of him, particularly his mother. And he was really hyperactive, and she couldn't do anything. And couldn't take him out, but mom was also pregnant at the time, and we had concerns about the safety of the newborn. And mom also had previous substance use problems, and I was concerned, that with ongoing stressors, would that lead to a relapse? And so it certainly wasn't something we did lightly, but I think in the long run was probably beneficial. Well, I guess I'm justifying myself there a little bit, but I think in general, though, it's something that I don't feel comfortable with, although other people might. Dr. McNeil, welcome. And all you have to do is unmute yourself.
So Rob, just along that same line, as we've been talking about, I have one patient that I did start medication on just around the age of 3, because we actually had all of the services involved in trying to help with the behaviors in this child who had numerous issues. And the supportive services, the speech and language OT, behavioral therapists actually came to me and said, we actually can't work with this child because he's just so out of control and hyper that we can't actually get anywhere with him. He needs something in order to sort of settle him down so we can actually do the work. And that's the only time for that sort of very young child. I was extremely uncomfortable. And as Maria said, I used clonidine in that case, and it actually worked extremely well. But we had all the services, and it was the services coming to me saying, can't do anything unless you settle this child down. So it was helpful to get them all involved and to hear that. And I felt a little bit more justified with that. And in the end, it actually worked out very well, but it is very uncomfortable.
Oh, absolutely. And the only other person I've ever used medicine under the age of 4 was a young boy who, was involved with behavioral services, but had really significant, he had macrocephaly, but also had really significant self-injurious behavior consisting of banging his head. And people were really worried about him hurting himself. So Michelle and Maria, if I can ask, why in 4-year-olds and 3-year-olds would you use clonidine over a stimulant? And I don't want you to think that I'm questioning you or suggesting it's wrong. I'm just curious as to what the rationale would be.
Yeah, I think for me, certainly studies and that sort of stuff have been done in the older kids, and there hasn't been a lot, and you've demonstrated it quite well in the talk. There hasn't been a lot of great studies. Again, when we're looking at sort of an ADHD diagnosis and the scales that we use to make that diagnosis, that's really intended for, as you sort of mentioned, when the kids go to school. Yep. So that, age 5, age 6. So it's hard to really use those sort of same scales that I would use to make that diagnosis. Because again, the child's developmentally 2 or 3, we don't actually have good scales to sort of look at, is this an ADHD? Is that where we go with stimulant base versus, again, this child has a multitude of health issues, not just sort of ADHD, and felt a little bit more comfortable with the lower doses of clonidine that I could use in a mom who I trusted and that sort of thing. So that tends to be for me. It's not that I don't use stimulants in a 5-year-old, even though I can't use a Connors questionnaire until they're 6. But yeah, I just don't have any really good rating scales that have been studied in those really young kids. Because as you said, developmentally, they are going to be a little bit more hyper and a little bit more aggressive and those sorts of things because they're 3. Right. And maybe developmentally 2 and behaving somewhat. I mean, this kid was well over and above that. But that's probably why I don't use stimulants at a super young age. I'm not too sure for Maria.
Yeah, I agree. I think it's mostly because of the aggression piece. And I don't know if the aggression is from anxiety or oppositional behaviors as opposed to ADHD. There's been a few times where I've been quite certain it's probably ADHD and I've used a stimulant at 5, but it's just when I'm not quite sure what I'm treating and I'm going to try to treat the aggressive behaviors if I can with the clonidine, and I start pretty low with dosing.
Okay, that makes perfect sense, actually. Thank you for clarifying that. Speaking of clarifying, Claire, feel free to go ahead. You just have to unmute yourself. Yep.
Yeah, it's that the host muted me. Yes, I put a couple of comments in the question and answer. I think it comes back to getting those behavioral strategies. So the Canadian Pediatric Society, endorses the use of medication for ADHD in kids 4 to 6 when behavioral strategies have not been effective. And so I think that's the key, is trying to decide, is it the case that Dr. McNeil outlined where everyone's been involved, you really have maxed out your behavioral strategies, or the more common scenario in which, perhaps someone's accessed the therapy, but it hasn't really been what we might think is optimal behavior management strategies. I think that's the real difficulty. I do sometimes start with clonidine in younger kids, and the reason is that they often have significant side effects to the stimulants, and I think that's been shown in studies. So their appetite goes way down and they stop sleeping. And often the preschool kids with ADHD, not only are they hyperactive, impulsive in the day, but they also are not sleeping at night. So a lot of times clonidine, if I've already tried, especially if I've tried some melatonin, some clonidine at night helps them sleep, has the benefit of providing some improvement in ADHD. And then if they get a good night's sleep, often that improves behavior through the day. And then it also sets them up so that if we do start a stimulant, they've got some treatment underway to help them with the sleep problem rather than making it worse. So I think that's the thinking. That being said, the stimulants are the most effective for ADHD. behaviors, and I usually tell parents that. So sometimes they'll opt for the stimulant because the behaviors are so difficult through the day.
Well, and I think that with one of the studies of methylphenidate in children and adolescents with autism, I was at a conference that was being presented, and one of the people in the audience said, that the side effect profile looks very much like what you might see in preschoolers in some studies of preschool stimulants, where there's more mood symptoms and things like that. And so what I sometimes say to parents now is, if their children have tried a stimulant, but it was under the age of 6, let's say, I think it might be worthwhile reconsidering at some point in time if they didn't respond, if there was significant side effects. On the other hand, if they were 8 or 9 and it didn't help, then I don't think there's any point in revisiting it. So definitely they're different, I think, in the younger age group. And Claire, I was just looking at your comment about, that the CPS, Canadian Pediatric Society, supports the use of medication when behavioral strategies haven't been effective. But I guess given what Jennifer and I were saying earlier about how there are long waiting lists and stuff like that, if behavioral services aren't available, what would you do?
I think I would have a look at the dysfunction, right? And sometimes I talk to families about the side effects of being untreated. So, if they have to be supervised so closely to keep them safe that they can't play with friends, you can't go out to a restaurant, you can't take them shopping, they can't attend school, there are side effects to all those limitations on experience. So sometimes we just have to use some medication to just at least provide something, let them go to school, let them participate in life, recognizing that that's not optimal. And then I think we just have to keep advocating, as a group, perhaps, for behavioral treatments. Like, I'm very disappointed that P is really not very available. Other things like 1, 2, 3 Magic, like a lot of things that were provided, and of course COVID affected it, but even before that, parenting for parents of kids with disruptive behavior disorders, that should be readily available, and it just doesn't seem to be.
No, and the long-term consequences of that, both individually and societally, are potentially going to be huge.
I agree.
And I wonder sometimes, and I think it's the same with people with anxiety, and that's the other reason to start with behavioral sort of CBT first, is if we're talking about a 6-year-old or 5-year-old and medicine is significantly beneficial, does that reduce the parent or caregiver's motivation to do the harder thing, which is the behavioral stuff? And I don't know that, but I've wondered that more with perhaps CBT for anxiety, but it's something that's just sometimes in the back of my mind, that if we make it too easy, and which is not to say that we want to make things hard for people, but I think we really have to push the idea that behavioral stuff is needed as well.
Yeah, we need to titrate so there's just a little anxiety left over, just a little impulsivity, so they have something to work on.
Yeah, I don't know if we'd want to put that in any guidelines. No. And I assume that you are not speaking on behalf of the Canadian Pediatric Society at that particular moment? Or the government of Ontario?
No, but I do think that the drug companies in some of their marketing for ADHD talk about ADHD remission, and I actually disagree with that approach. I mean, this is a lifelong condition that requires multimodal treatment, and so it is not like cancer where there's remission. It's a lifelong condition. So I think that's really what we're talking about.
Well, but that's a great point too, I think, Claire, because I've seen a number of kids over the years, where 1 year in school with one teacher, their behavior is out of control and nothing seems to help. The next year with a very different teacher and a different approach, they do fine. And so I suppose, you can argue, I guess, our drug companies, because there's remission, but that doesn't tell us anything about 6 months from now and how things might change.
Exactly. And of course, over the lifespan, there's different expectations and demands and challenges. So just like any condition, autism, similarly, it's going to look different as the expectations change.
All right. Any other questions or comments, concerns? Sorry, Afzal, and welcome, Afzal, by the way. But let me just, if you could just unmute yourself. So Dr. Mohammed is a community pediatrician in London.
Can you hear me?
Yep.
Well, I spent the last 10 minutes trying to figure out how to do this.
Yep. It's not simple.
Anyway, first of all, it's an excellent discussion, very practical. You know, the very first comment you made initially when you started the presentation, saying that, look, we do not have any cure for any of these illnesses. The main aim here is to try and treat symptoms. So I think that was excellent, and that's usually a fairly good guideline for all of us. Now, the question you asked about is whether I've used medication in kids less than 4 or 5. And you know what, just like yourself, I think maybe I can count on one hand how many times I've done that. And the last time I did it was just 2 weeks ago. And again, most of the times, you know, mothers come in, they have a child who has aggressive behavior and they're not functioning, particularly at school, because this kid just started junior kindergarten. And every day the mother is being called because of something that has happened. She eventually came to me and in tears and said, look, Dr. Mohammed, you have to do something, otherwise I'm going to break. Anyway, I did start this kid on bifenton, 10 milligrams. I saw him 2 weeks later, and she said, you know what, it has taken the edge off things that I can manage at home, and the school is calling me less. So I know it's not indicated, you know, you probably shouldn't use it. I use it with some hesitation, but, you know, sometimes, you know, you just need to use it and maybe target some symptoms and bring some comfort and some sanity to parents.
Well, yeah, absolutely. You know, it's the, I think, you know, what we're taught in child psychiatry, and pediatrics, you know, we can't think about a child without thinking about their context of their family. And
Sure.
If parents are stressed and tired, their ability to do behavioral interventions and their patients are going to be far less. And, you know, I've had lots of parents say over the years, you know, that when their kids are having problems, every time the phone would ring, they would sort of be startled and think, oh my God, I hope it's not the school again. And, you know, I've had parents who've had to quit their jobs because of that, which obviously then puts other stressors on the family. And I think if those are areas that we can make a difference, and I always say I wouldn't prescribe medicine to make a parent feel better, but I think we can often tell how a child is doing by looking at their parents and seeing how well they feel and how well they're doing.
Exactly. So, you know, I think, and this was a single mother, and, you know, I mean, she was quite happy, at least. And then we didn't have any of the, you know, potential side effects yet. So, you know, I mean, the child just needs to be closely monitored, and we'll keep an eye and see how it goes.
Yeah, well, that's great that it worked out that way.
Yes.
Okay, so Ben, do you want to say something further and then maybe be the last comment, unless other people had pressing things to say? All you have to do is unmute yourself, Ben.
Yeah, the only other comment I would like to make, we've been talking about before one starts medication to see if you can get a good psychological behavioral assessment. What about a basic pediatric neurological workup before one starts medication? What would you consider would be a baseline pediatric neurological workup before beginning medication?
I guess it would depend upon which medication, Ben, but I think unfortunately, you know, waiting lists are really long, and even to see a neurologist is not a short period of time. I think what we're blessed with at CPRI anyway is having, you know, pediatricians here, and the same with over at the hospital. But I think for community people, it might be difficult. In general, and I can only speak for myself, I think a screening neurological exam just to rule out any other obvious problems would be all I would do. And a few years ago, there was probably about 10, 12 years ago, the American Heart Association came out with a recommendation that anybody starting on stimulants should have an EKG done first. And the HMOs in the United States sort of went crazy because of the time and I guess their expense involved. And so the American Heart Association backed off and said, you know, that a good heart history should be done on people before starting a stimulant. And if there's no evidence of problems, then it's fine to start them. And I came across yesterday, I think, the resident and I were looking at this. There was a nice meta-analysis of people sort of the cardiovascular effects of stimulants. And I think the reality is they're remarkably safe medicines. My understanding generally is that there are, when you're talking about huge sample sizes, you can see statistically significant differences in heart rate and blood pressure, but for the most part, clinically meaningless. I think, you know, if you have a sample size of 20,000 people, even an increase of 2 or 3 beats per minute is going to be statistically significant. But again, for myself, I would just sort of, if I was concerned, I would ask one of the pediatricians to see somebody, but otherwise I would do sort of a screening neurological exam, and that's it. It'd be nice to have more, but it's just not as easily available. And the same with, you know, I think it's ideal to have a psychologist and a speech and language pathologist on board before starting medicine. I think, especially for people working out in the community, I don't want to say that's impossible, but I think it's an asymptote approaching, you know, impossibility. I think it's just remarkably difficult to do, unfortunately.
Very good, thanks. I was particularly thinking about seizure potential.
You know, so Miriam Nouri is a neurologist over at Victoria Hospital, and she and I have talked a lot about this. And I think one of her strong beliefs is that people with epilepsy and ADHD are probably grossly undertreated for ADHD because of worries about stimulants increasing the risk of seizures. And there have been a few position statements from, I think, the American Academy of Neurology stating that in general, you know, stimulants, well, methylphenidate anyway, does not increase the rate of seizures. That obviously there's going to be some people it might, but for the most part, they feel, and they've recommended, taking into account all other factors, stuff, that epilepsy should not be a reason to not start somebody on a stimulant.
Thanks for the update.
Yeah, methylphenidate in particular. Okay, so why don't we, actually, I think there might be one more question here. Dr. Frey from University of Hamilton had a comment, but thank you, Julia. It's nice to see you. All right, thanks again, everybody, and we will see you all next month. Thanks again, Judith.